Hi, this is Brian Kim. I'm going to share with you this case of a patient who had a Descemet detachment at the main incision. And so, as you know, when I do cataract surgery, I always lift the incision when I go in with the phaco tip, with the chopper, and I also go in without activating irrigation. Both of those things are to reduce the risk for a Descemet detachment. This is a case of a patient who had an iStent inject W. And so you'll see I push the device in, and as I do that, it actually hits the corneal roof and snags the endothelium and peels it off. And so I will have to adjust how I introduce the device with that technique so I minimize the risk for Descemet detachment. But this video is going to show you how I deal with the Descemet detachment once it happens. So I'm done with the phaco here, and I'm planning on doing the iStent inject W. I'm going to go ahead and inject some viscoelastic to fill the anterior chamber and place a dollop on the corneal surface. I'm going to get my gonio prism as well as the device ready, but go ahead and pay attention. It happens very, very fast here. I introduce the device and it causes a tear. I'm going to show this in 0.125x speed here. You can see as I introduce the device, it causes a little rip in the Descemet, and it shows in this red window here. It's caused this little rectangular flap. And if it was a small tear, like happens with some phaco cases, it's not that big of a deal, and it kind of will fall back into anatomical position as it should. However, you'll see throughout the case that this little flap does not want to sit appropriately in the normal anatomic position, and it's dangling down. And so I'm going to have to find a way to manage this. But again, in the future, when I'm going to have a case like this, I'm going to have to make sure I push down on the floor of the incision to minimize any risk or contact to the corneal endothelium. So this is the case after I've put both eye stents in. You can see the tear through the red reflex on my incision there. It's like a little trapezoidal tear there. So first things first, when I introduce the INA handpiece, again, I'm going to not go in with active irrigation because that can push off and peel off more of the Descemet detachment. So I go in without irrigation, and then I'm going to start to do my INA of the viscoelastic. And all of this is going to be fairly routine as far as, normal cataract surgery, removing the viscoelastic from within the bag and underneath the lens, removing the viscoelastic from the anterior chamber. However, the key will be not to use the fluidics and the vacuum near the incision, because if I do, I can actually grab the Descemet detachment and peel off more of the Descemet. And you definitely don't want to aspirate that little flap there. You can see the flap floating around right there as I'm doing the INA. I'm done with the INA. I'm going to go in, pushing BSS, and then I'm going to come out. You can see the Descemet tear was flapping around as the irrigation was being active. That was causing quite a bit of turbulence there. I'm being careful when I hydrate my incisions here. Very, very careful not to use aggressive fluid when I'm pushing through the incision, because you don't want, again, that tear to get propagated if I use too much fluid. And if it's sudden loss of resistance and it hits that area, it can just cause the Descemet to split even more. So I'm just being very ginger and very controlled with the pressure as I'm hydrating the corneal incisions and trying to stay away from the tear. You can see there's quite a bit of heme coming out, and that's from the iStent inject device. And so I increased the pressure as I did that, but I can tell that the flap is not sitting flat. And so I'm messing with it and trying to do my best to control the flap. I put some air in it to see if I can push it down. I evacuate the air, thinking, okay, maybe that did it, but I can still tell that the flap is not sitting against the cornea. So now I go ahead and put an aggressive bubble, and I'm pushing on the eye. And then I go ahead and remove that air bubble. And I'm thinking I'm good, but see, as I'm pushing more fluid, you can see the flap detach from the cornea. I'm redirecting fluid towards the tear, thinking I can just push it up. It's really not working. So I decided to treat this like a Descemet case. I really put a lot of air at high pressure. I turned the eye all the way away from me, just like I was going to do a MIGS case. I put a lot of air at high pressure, and I'm turning the eye away from me. By doing it that way, the bubble is going to be facing directly towards the tear. And so by turning the eye away from me, the incision is going to be straight up. The bubble is going to provide some level of tamponade. I'm actually going to massage the surface of the incision, just like I do with my Descemet cases. I'm massaging any potential interface fluid from the incision, which will hopefully encourage the tear to stay against the corneal tissue and giving it some extra time and that pressure. So again, just like a Descemet or a DMEC, I'm using that high pressure to tamponade the Descemet against the corneal tissue, and I'm going to give it some time as I do this. Hopefully that will allow it to attach. So again, I just put a little bit of air in the beginning thinking it'll just push it up. It didn't work. I used high pressure and did the same thing. It didn't work. But this time I'm doing high pressure, turning the eye away from me, making sure the incision is facing up, allowing that bubble to compress the incision maximally by doing it this way, massaging the incision. And the other difference is, just like a Descemet or a DMEC, I'm going to hold this high pressure with the air bubble for longer. In this case, I held it for 3.5 to 4 minutes. I go ahead and evacuate the air. You could see it was such a high pressure, it took me some effort to even put the cannula in. And I remove the air, and lo and behold, thankfully, I see no evidence of the tear now. And you know there's no evidence of the tear because I don't see that little wrinkle on the incision there. I didn't see anything moving around. And quite honestly, now I can't even see it. And so this is a case. Once I'm done, you can see that there is no evidence for a tear. You can see just a very faint outline of where the tear was, but it's definitely sitting flat now. And I was able to re-tamponade the Descemet into normal anatomic position. So the tip is to use high pressure with an air bubble, turning the eye away from me and allowing the incision to be pointed up, allowing that bubble maximum effect, allowing the Descemet to be tamponaded against the corneal tissue, giving it some time, massaging the interface to remove any potential fluid. And this was the way I was able to handle this Descemet detachment. So I hope this was helpful to you, and I thank you for your attention.